Good evening, everybody, and welcome to this evening's Prescribing Pre-Exposure Prophylaxis for HIV in General Practice Part 2. Tonight we'll be focusing on conducting a sexual history. My name is Samantha and I am your host for this evening. Before we make a start, I would just like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'd like to introduce our presenters for this evening. We're joined by Dr. Brad Mackay and Dr. Nathan Ryder. Brad is general practitioner at East Sydney Doctors in Darlinghurst. He's an HIV S100 prescriber and host of the Embarrassing Bodies Down Under TV show, TV presenter and medical advisor for the Today Show and Today Extra on Channel 9, and host of HIV in Podcast. Nathan is a sexual health physician with 15 years of experience in HIV management in urban and rural Australia. He's the clinical director of sexual health at the Hunter New England Local Health District, the HIV support program coordinator at the Hunter New England LHD also, and conjoint senior lecturer at the Kirby Institute, UNSW, and the University of Newcastle. So thank you, Brad and Nathan, for joining us tonight.
Cool, thanks, Sammy.
No worries, and I will hand over to Brad now to take us through our learning outcomes for this evening.
Well, hi guys, it's Dr. Brad Mackay here, or just Brad, that's fine. But yeah, thank you so much for joining us on this lovely freezing cold night around New South Wales. It's good to have everybody here listening in and learning about preventing HIV. So tonight, our learning outcomes are all up on the screen. So by the end of this activity, you should be able to identify patients who are at high risk or medium risk of HIV infection. You should be able to prescribe PrEP to appropriate patients, and we'll go through the step-by-step process with that. You should be able to complete a sexual health history and risk assessment, and that's really what we're going to be focusing on a lot tonight, like looking at sexual health and how to word our questions appropriately, and also obtain informed consent for HIV testing and appropriately communicate these results to a patient. So yeah, what happens if you get an HIV positive result? And then using appropriate techniques to engage patients at risk of contracting or passing on an STI, sexually transmitted infection. So this is just a reminder, like why PrEP? Why are we doing this? We have a New South Wales HIV strategy that we're following, and this is really under the umbrella of the United Nations and looking at a worldwide global strategy to prevent HIV around the world. So there's what we're trying to do is by 2020 is to virtually eliminate HIV transmission. So we're on our way towards that, but we're not quite there yet. And one of the ways of preventing HIV is by using PrEP. This has been a really key role, and this has really started to reduce the number of HIV infections that we are seeing around Australia at the moment. So yeah, so it's just PrEP is vital for what we're doing, and to work effectively, we need all of you guys as well. We're needing PrEP to be available to the population, to the public who need it, and we're trying to decrease those hurdles. So it's all your guys' job to help everybody out and to reduce HIV around Australia. So we'll get the evening's festivities started by putting a question up to you guys. We've got a poll here. So this will be easy for some people who are at the last webinar. For the newbies, this may be a little bit difficult because we are throwing you in the deep end. But yeah, what are the correct medications prescribed for PrEP? Please select, I think it's like A, B, and C. So the letter A is it tenofovir disoproxil fumarate and emtricitabine tablet, 300 milligrams / 200 milligrams once a day? Is it tenofovir disoproxil fumarate 300 milligrams and emtricitabine 200 milligrams and efavirenz 600 milligrams once a day? And C, is it tenofovir DF 300 milligrams plus emtricitabine 200 milligrams plus rilpivirine 25 milligrams once a day? So we have 41% of people have put their money down on A, so tenofovir disoproxil fumarate and emtricitabine tablet, 300 / 200 milligram tablet, and that is the correct result. We've got 33% of people on B and 26% of people on C. So yeah, so we are, I knew it was throwing everybody in the deep end, but yeah, we are talking about 2 drugs. So that was the first answer there. So A, using tenofovir disoproxil fumarate and emtricitabine. It's 1 tablet a day, and the script that we'll go through as the webinar goes, it's for 30 tablets and 2 repeats. So for a 3-month prescription. It's really important that you all know that you are able to prescribe PrEP. This has been a change from April the 1st of this year. There are many other HIV medications that you need to do an S100 course for, and I encourage everybody to do that. But even from today, you can prescribe PrEP for all of your patients. So if they're coming and asking you, you have that permission. So most of the time, the authority just pops up on the computer. I'm used to it being automatic. If you're writing a manual script, then the streamline authority number is 7580, but you probably don't need to remember that. And yeah, if you're trying to find it on your computer, this is a screen to sort of show you what you're looking at. On the left side of your screen, you can see that if you're looking up tenofovir, I know it's spelt very, very strangely, but that's it. It's the 300 milligram / 200 milligram tablet. It's 30 and then 2 repeats. So if you're looking at that, that's what you're after. Some people who have HIV are on the same drug, and they're using, like if people are writing prescriptions for that, we've usually got the 5 repeats on it. So you don't want to click those. You're wanting to go to the 30 tablets and 2 repeats. And sometimes this is really complicated as well. So my cheat sheet way of doing it is by typing in Truvada, so TRUV, and then it will pop up, and it's only got like a couple of options that you can use. And again, it's looking for the one with 30 tablets and 2 repeats on it as well. So we'll just go to the next screen here. And I think this will be sent to you as a PDF at the end of the webinar. So everybody should be able to get this. You can get this from the ASHM website as well. And this is known as the PrEP prescribing pathway because we love alliteration. So this tool has been made by ASHM to make prescribing as easy as possible. Even though it looks very complicated, we will go through it step by step. So there's 5, on the left side of your screen, there's 5 steps that we'll be following today. So the first step that's there is to see if your patient is behaviorally eligible for having PrEP, if they're high or medium risk of getting HIV infection. It's also like number 2 is to see if they're clinically appropriate or clinically eligible for PrEP. So see if it's safe for them to take it. Step 3 is which other tests you should be performing. So which tests you need before starting PrEP, and also seizing the opportunity to screen for other STIs. That's really, really important. So I'll be going through that today too. Step 4 is how to prescribe the PrEP prescription. And then the final step is ongoing monitoring. So what do we need to follow up with our patients? What do we need to tell them? So this is what we'll be going through, and so what we're needing to know. So we'll be going through those 5 steps, and we'll review the practicalities of prescribing PrEP. Nathan will be going through that in a minute, but we'll also be getting into the nitty-gritty details of taking a sexual health history and how to determine if a patient would benefit from taking PrEP in the first place. Now, I'm sure that some of you will be already very well practiced at taking a sexual health history, but many doctors out there still find it difficult to initiate that conversation with their patients about sex. So for many of you, it may be a number of years since you've been on a dating app, or it might be so long from your dating life that you weren't dating apps probably weren't around when you were dating. But the language of courtship has changed dramatically over the years, and we'll be giving you some practical tips and talking about some appropriate language to use with your patients as well. So this is step 1 of the ASHM PrEP prescribing pathway. And this is about behavioural eligibility. So assessing what the patient's getting up to and whether they'll benefit from being on PrEP. So I'll hand the next few slides over to Nathan, and he'll be reviewing what's necessary when we're taking a sexual health history. And we'll also be remembering that assessing for the risk of HIV and other STIs is only part of the sexual health history. So before we go to that, before we go to Nathan, I think we've got a poll. So I'll hand over to Sammy to ask about this poll.
Absolutely. So we've just launched that second poll for you there. So the question for this poll is, which clinical consultations are appropriate for you to ask a patient about their sexual history?
Cool. So the vast majority of people have said all of the above. So 96%. The question was far too easy. So yeah, it's certainly taking any opportunity to talk to our patients about it. But yeah, so I'll hand over to Nathan to start the next section of this.
Okay, thanks, Brad. So I think if we move on to the next slide, yeah, okay. So yeah, so the answer to the polls, really all of those situations would be a perfect time to take a sexual history. So clearly this whole webinar is around HIV risk, and that's what I guess the focus of a lot of our discussion is going to be. But in clinical practice, obviously taking a sexual history is going to come in handy in a lot more situations than just that. So we've got several things up there on the slide there. I guess many of you are probably already taking sexual histories in these situations. But I guess one that often comes up for me when I do general education around sexual history taking is really the importance in chronic diseases, and that often gets forgotten about. That most chronic diseases do have quite a big impact on people's sexual lives, and making sure that you think about asking these questions in that sort of situation. And of course, we know a lot of our medications that we're prescribing will have an impact. So really, any of these situations would be excellent times to ask your patients about sexual history, and your patients will thank you for it. So if you'll go on to the next slide. So just going to step through some reasons why we might take a sexual history, and I mean some of them are going to seem pretty self-evident, but I think it really helps to really unpack why we're doing it. So the first thing is obviously, unless you really talk to your patients about these things, then you're not really going to understand what's going on in terms of their sexual lives and their sexual behaviour, which is going to make it very hard for you to make appropriate recommendations and care for them properly. For a more practical sense, obviously the test that we might perform for the patient is going to very much depend on who they're having sex with and what sort of sex they're having. It's also going to help us provide some counselling around risk reduction. As we know, risk reduction is not about a lecture, it's about understanding what's going on for that person and helping them come up with some strategies that they can put into practice that work for them. And finally, the test results are never black and white, well, rarely black and white. And understanding what that test result is going to mean for that patient obviously relies on us having some understanding of their particular situation. And one thing that I guess comes up quite a lot is around informed consent, or what used to be called counselling for HIV. So as I'm sure hopefully most people on the line will know that we don't really talk about HIV counselling anymore in relation to testing, but we do talk about informed consent as we do for any test. But for any test, you can't really get true informed consent unless you understand their risk. And so taking a sexual history is I guess part of informed consent for all of the tests you might do, HIV and otherwise. We go on to the next slide. So from the other side of it, taking a sexual history, or I guess participating in the sexual history with you, has a lot of benefit to the patient as well. So talking to another person about what's going on in their lives sexually, what sort of behaviour they're undergoing, and what prevention means they're using, can help them reflect on that and what they may want to change about it. Obviously, the process of discussing why you're asking these questions and what it means is going to help them understand why you're recommending certain tests or certain treatment, and may help with them complying with that treatment. And lastly, it's really quite amazing how much asking about these sensitive things can help really build that engagement. And so I guess that's a two-way street, that it's hard to ask the questions until you've engaged properly with that patient. But equally, if you take the effort to do it properly, that really helps build that relationship.
This is a very interesting question. So what stops you from asking your patients about sex? So is it A, lack of time, B, lack of practice taking a sexual history? Is it C, embarrassment or shyness? Or is it D, worried about your patient's reaction from bringing up sex? So we have, as the results, 33% of us are saying that it's a lack of time bringing it up. 21% are saying that it's a lack of practice taking a sexual history. So you have come to the right place because we're looking at that. 6%, very few of you are embarrassed. So that is a very good thing. And 41% are worried about the patient's reaction. So yeah, a bit of a wide range of ideas there. So yeah, so I'll hand back to Nathan to continue on here.
Okay. Yeah, it's amazing. I've seen those sorts of numbers come out in lots of different audiences, and it's incredible how consistent it is that those barriers are really the ones that come out again and again. And there's a lot of research showing that those barriers are just often brought up by GPs, but a bit of practice can often get us past that. So I guess before you even start, there's a few things you can do to, as the slide says, set yourself up for success. So these are things that are going to happen before you start asking the questions. So a really important one is to just consider and reflect on your own cultural background, your own beliefs about sex. Obviously, they're your personal beliefs and you're entitled to them, but you need to, I guess, reflect on how that might impact upon your body language and how you're going to deal with the consult and be able to manage that. The next thing is to think about the environment. So physical environment, so how private is it, or more importantly, how private does the patient perceive it to be? And secondly, who else is in the room? So if a partner's there or even a parent sometimes, that's going to make a big difference to the information that you obtain. And you might want to think about separating people or moving to an appropriate location if required. So before you launch into the questions, obviously you have to establish some level of rapport. I don't think that'll come as any surprise for you when you're asking other sensitive information, but obviously it's really important with sexual health history. And paying attention to the non-verbal cues, really picking up on if the patient is really super comfortable with this and it's okay to go, or they're clearly not comfortable and they're going to need a bit more preparation. And the last point, I guess, really is similar to the first one, that you really need to go in with an open mind and accepting a non-judgmental attitude to what the patient's saying. You don't have to agree with them, but you do need to go in with a non-judgmental attitude if you want to get anywhere. So if we move on to the next slide. So once we've got ourselves set up, we're comfortable that it's a private space and that the patient feels comfortable. We really need to explain why we're asking the questions. And I really can't stress this enough. I think this makes a massive difference to how well it goes. And if you start out on the wrong foot with something so personal as this, it's very hard to pull back. So the patient needs to understand why you're asking this. You can't come out of the blue and ask someone a very personal question about their sex life. But if you start with, look, I'm going to ask you some personal questions because it's going to be useful in helping me care for you. You might be more specific depending on what the sort of context is, I guess. But the person's going to be much more receptive, especially if you ask them if that's okay with them, if they've got any concerns about that. And I always start with the easier questions. So obviously in my clinic, it's, people come in expecting to be asked these questions. And even then, it makes a big difference if we start with something relatively straightforward, like, are you sexually active or are you having sex with someone, versus launching into quite a detailed question about when's the last time you had unprotected anal sex, which is obviously where we need to end up. So start with the easy questions and then work your way forward and gauge the speed on their body language and their responses.
It's like foreplay, Nathan.
That's one way of putting it.
Just to put it into context, that's fine.
So we move on to the next slide. All right, so this is a little mnemonic that I actually come across from the US Center for Disease Control, but you see it in a number of resources. And so it's the 5 Ps of sexual history taking. And I guess it provides a bit of a structure to go through. It's obviously best if you put it into your own language. But essentially what we want to know is whether the person's having sex with men, women, or both. We want to know some sort of information about timings, the context of the partners. So are they casual or regular, which is, you know, a bit of a grey zone, but I guess these days it can often, you know, come into whether they're meeting them online or on apps, whether they're anonymous partners, whether it's someone they're in a relationship. So just having that sort of global context. Then obviously moving on to the types of sex. I'm not a big fan of this being a list. I think you contextualize it. So in a heterosexual couple, you know, there's a big difference between oral sex and vaginal sex in terms of pregnancy risk and STI transmission. I don't think it's, you know, that important most of the time to ask about anal sex in that situation. Whereas with gay men, it's very important. The risk of HIV is starkly different between oral and anal sex. And the rate of condom use is also quite different. And so I think contextualizing that, not just asking incredible details all of the time. A past history of STIs can be quite useful. Past STIs is one of the strongest predictor of future STIs. Obviously protection against STIs and prevention of pregnancy. And whilst it's not in the 5 Ps, you sometimes see the 6 Ps, and the 6th P is performance or pleasure. And that, I guess, comes into when you're taking a more general history around the impact of chronic disease and whatnot, asking someone if they've got any issues with their performance or issues with the enjoyment of their sex life. And if you, I guess if you go through those 6 Ps, then you've pretty much covered everything you need to do. So I think it's back to you, Brad.
No problem. So yeah, so I think we're getting back to the preparation. So still on step 1 with behavioural eligibility, and yeah, just in the middle column there, I've sort of like written down, I suppose it's some of the questions that I ask and how I phrase it. So just to give some examples, I usually sort of say, like, if I'm approaching a sexual history, are you having sex with men, women, or both? That's my easy way of doing it. Often I'm surprised by the answer, so it's always good to keep everything open. I usually sort of ask about sort of sexual history, injecting practices in the ways that are written there. So are any of your sexual partners HIV positive? Most people are pretty happy to answer that question. They're not too shocked by it. Do you usually top or bottom? So that's, yeah, just if you're the top, the penis, or the bottom, pretty easy. A lot of my patients will be using those terms, and a lot of men who have sex with men will be using those terms. So feel free to use that as a question when you're out there. Do you usually use condoms? That's sort of like a general way, because most people are sort of be very embarrassed if they're not using condoms all of the time because they want to impress you. And then, yeah, if you're saying, do you usually use condoms? Are there times that you don't use condoms? Often patients will say, yeah, I use condoms 80% of the time, but 20% of the time I don't. Do you have access to safe injecting equipment? That's a very formal question. But yeah, so wording it however you're wanting to word it. And have you shared any injecting equipment? That refers to whether they're at risk of HIV, Hep B, Hep C, and what we've got to be thinking about for them. So these answers will sort of guide the assessment of your patients and whether they will be appropriate for PrEP or not. And I think we're going to be going into a bit of a role play with myself and Nathan. So I will be the patient and Nathan will be the doctor. And yeah, we'll sort of show you how a consultation will go. We will test Nathan's question style as a doctor and see how he goes. So the scenario, as we're starting off, I will be Jason, a 32-year-old male, and I'm just presenting to Nathan's practice to ask about PrEP. I've seen some ads about it online. So we will launch into our beautiful role-playing exercise with Nathan here tonight.
All right, we'll give it a go. So hi, Jason. How are you going? Wondering what you're here for today.
Yeah, not too bad, Doc. I've seen some ads about PrEP, and I was just sort of like, yeah, wondering if it's appropriate or yeah, if I should start it.
Okay, sure. Yeah, we can discuss that. So before we get into the details, though, I'm going to need to talk to you a bit about your level of risk for HIV and get a bit more of understanding about your sex life. So do you mind if I ask you some personal questions in that regard?
Depends on how personal they are, but yeah, that sounds all right.
Okay, sure. Well, look, let's give it a go. If you're feeling uncomfortable, just let me know. But all the questions I ask you, I assure you they're the same questions asked of all my patients in this situation. And so we'll just go through it. So just to start with, are you having sexual intercourse at the moment?
Yeah, I'm active at the moment.
Yep. Okay. Sure. So, do you reckon you could just give me a bit more information about whether you're having sex with men, women, or both, and sort of what sort of context you're meeting your partners?
Oh yeah, just with men. Yeah.
Just with men?
Yeah.
Yep. Okay. Sure. Well, do you want to just tell me a little bit about the last time you had sex?
Well, the last time was probably about 8 weeks ago. So yeah, so just I've got a friend that I catch up with every now and again. We sort of met on Grinder and yeah, just sort of meet up a couple of months when he's in town. Yeah, so that was sort of like the last time. So he's sort of due to be in town again pretty soon. So I was just wanting to know if I need to protect myself.
Okay. Sure. So when you meet up with him, what sort of sex do you generally have?
So I'm usually bottom, so he's a totes mask top. So yeah, so he's that's usually what I do.
Okay. Okay. And what sort of things would you do to protect yourself against infections?
Well, like the first time we sort of met up, I asked him to use a condom, and then he says that he's sort of HIV negative, and yeah, like I think he was on PrEP. I'm not sure what's happening now. I think he mentioned it a while ago, but we don't use condoms anymore because I've met up with him a few times, and he doesn't look like he's got HIV or anything. So yeah, I'm not too worried about it.
Okay. Sure. And are there any other partners that you've had in the last, say, 3 months?
Yeah, I've got another couple of guys that I meet up with. Yeah.
Okay. And is that sort of a similar type scenario?
Yeah, so with them, yeah, I think we started using condoms, but then yeah, like we were sort of used to having sex with each other, so yeah, we don't use condoms anymore.
Okay, sure. So you've got a few partners that you know, and you're pretty sure they're negative,
Yeah,
and you're a bottom and not using condoms. Is that right?
yeah, yeah,
Yeah. Okay. And all right. So I'm just going to ask you another few questions about your HIV risk, because other ways it can be transmitted is through particularly injecting drug use. So do you use any drugs at all?
No, I just have some dope every now and again, but yeah, nothing heavy.
So no injecting drugs, and do you use drugs during sex?
I've got a few friends that will sort of bring out a pipe every now and again, but yeah, I don't get into it. I'm just not interested.
Okay, sure. Have you ever had a test for sexually transmitted infections or HIV before?
Yeah, I went to a sexual health service about 3 months ago, and yeah, they did some checks and everything was fine then.
Okay, sure. So about 3 months ago, you were HIV negative and
Yeah, yeah,
had some other tests. Yeah. Okay, sure. All right. Well, look, I think that's enough information to get an idea of your level of risk. I'd love to tell you what I think, but I think I've got to put it to the audience, don't I?
sure. Yeah, yeah. So we'll take it to a poll for Jason. So based on Jason's sexual practices, do you think he is at high risk for HIV infection? So either A for yes or B for no. So the vast majority, so 94% of people are saying yes, and we have 6% of people saying no. So what are your thoughts, Nathan?
Yeah. So, I mean, I think the answer to this question is yes. I think this Jason is at high risk. So he's having condomless anal sex with no male partners. He thinks they're HIV negative, but he doesn't really know. He's relying on what people have said, and they're not in I guess, a close relationship. So we generally consider that to be an unknown HIV status. I mean, these people may generally believe that they're HIV negative, but that's a bit different to definitely being HIV negative. The other thing, which I guess we went a little bit off topic, but so using amphetamines during sex is quite a strong risk factor for HIV, and that, I guess, came out as well. Um, he had a negative HIV test 3 months ago, which is great, but he hasn't had a recent one, so we probably want to repeat that. But importantly, his last sex was 8 weeks ago. I'm not sure if that came out. I can't remember if we said that or not.
Yeah,
And that's going to come up really important, because that means that Jason's at risk of contracting HIV in the future, but he isn't at risk of a very recent transmission. So he's not really a candidate for post-exposure prophylaxis, more for pre-exposure prophylaxis.
So, so do you have many patients who come in and just say, yeah, all of my partners are negative, Nathan?
Yeah, I mean, I think it's becoming more and more common. So a lot of people meet partners online these days. It's quite common to use the settings on the sites and the apps to communicate your status. I'm in a regional area, so there's probably a little bit less sort of venue and anonymous sex that we see. Obviously, it still exists, but it's certainly less than I saw when I was in Sydney. So a lot of people do know their partners. I guess PrEP's also changed it a bit because quite a large number of people are on PrEP and hence will feel they know their status. And yeah, I mean, so I think a lot of people do come in saying, look, I know these people, I don't feel I'm at risk. But if you flip it around, we know a lot of the new HIV cases, do fall into that group where they really felt they weren't at risk because they thought they knew their partners. Can be quite a false insecurity in some situations.
Yeah, I always tell my patients that it's my job to play devil's advocate, and that even if they trust their partners, I don't. So I give them that permission to just presume that they could be at risk, and yeah, most patients are sort of receptive to that.
Yeah.
So
Okay, so I think back to me. So yeah, so we're just really talking there about the behavioural eligibility. So step one was assessing behavioural eligibility, and so we've established that our fake patient Jason is eligible from a behavioural sense, so he's in the high risk category. So the next step 2 is we're moving on to clinical eligibility. So I think we've got another slide on that one.
yeah.
Yep. So to assess clinical eligibility, we're going to need to do some testing. So really the main things that we need to know for clinical eligibility is the HIV status and the renal function. So the HIV status, because if you already have HIV and you take PrEP, which is a partial HIV treatment, you can potentially induce resistance. And obviously it's not going to do any good. So we need to know that for certain. And the major risk factor of PrEP is a very small, but it is there, risk to renal impairment. And really the only situations in which there has been some significant problem has been people that have pre-existing renal impairment. So we really need to identify that the person has normal renal function, as in an eGFR greater than 60. So we need to do the test on the line. Hepatitis B, that's there as a baseline to make certain because, despite the fact that it is recommended across the board for any high-risk gay men, there's a special reason for testing in PrEP, and that's because, as I'm sure most of you know, tenofovir, that's a component of PrEP, is also a drug that's used for hepatitis B treatment. So if you've got someone with chronic hepatitis B and we put them on PrEP and they stop and start, as they may choose to do, there would be at risk of a flare of hepatitis B from stopping and starting treatment. So we really want to know their Hep B status. It doesn't mean they can't have PrEP, but you would need to make sure they understood the risks of stopping and starting. In terms of the HIV test, one important thing we need to know is the window period. So we need to know they're negative at the start, and there's a 6 to 12 week window period. The labs will all recommend 12 weeks. That's the official window period. Clinically, we're generally pretty happy with 6. So we really got to be mindful of that when we're thinking, does this person have HIV or not? So we sort of touched on this before, and we're going to a bit more detail now. So what happens is the history is a little bit different, and Jason had have come in saying he'd had receptive anal sex in the past 72 hours. And that's actually pretty common, because if you think about it, people have to, have some reason to come and see you. It often does relate to a concern they've got, which is recent. So this will come up in real life, not that infrequently. So if there's been exposure in 72 hours, we need to think about post-exposure prophylaxis. So if you go on to the next slide. So post-exposure prophylaxis is taking the same drugs, the same HIV drugs, but after an event, post, to reduce your risk of contracting HIV. So probably most of you have heard it in relation to needle stick injuries. We know that it works quite well, probably 70 to 90% effective. The NPEP you'll see in the title, that just means non-occupational PEP, the sort of bit separated, occupational versus non-occupational, but essentially it's the same thing. Take Truvada, or the same drug, within 72 hours of exposure, and that will reduce your risk of HIV infection. You can get information on this. If you look at the flowchart, you can see there's a PEP hotline, and you can ring up and get information. And there's also a sexual health info link line. So if you go on to the next slide. So I think, yeah, that's one. Yeah, so it's exactly the same two medications between PEP and PrEP. It's just whether it's before or whether it's after. But really the reason why it's different and you need to get your head around it is because if they've had an exposure recently, you can't just give them a script and say, okay, go to the chemist and pick it up, because they may not necessarily get that within 72 hours, particularly as they probably haven't seen you the next hour. They're probably going to be partway through the 72 already. So you need to make sure they can get it. So you need to facilitate that. PrEP is obviously continuous, whereas PEP, post-exposure, is 1 tablet a day for 28 days. We always, because they're not 100% effective with PEP, we always make sure they get follow-up testing afterwards, and we usually recommend that at around 4 to 6 weeks when they finish the treatment, and then 12 weeks is the definitive final one. So if we go on to the next slide. So essentially, if you're in this situation, so you've got a person coming in, you've assessed them for PrEP, or they've requested PrEP, but you work out they've had a recent risk, then what we recommend is that you ring one of these two numbers on the screen, the PEP line or the InfoLink line, and explain the situation, and they will help you work out the best way to go. So sometimes that might be referring to an emergency department or a sexual health clinic or an S100 prescribing GP, or a GP that can prescribe HIV medications. Other times, particularly if you're near a pharmacy that stocks PrEP, you might be able to give them a PrEP script and start them immediately. I do that quite a lot because I know there's a pharmacy near me that has it in stock, but that's not going to apply everywhere, and that's why you need to ring up and get some advice.
So if we just pick that apart a little bit further, Nathan. So if somebody's coming in and they've had unprotected sex in the last 72 hours, so say they've been bottoming, then if you're wanting them to be on medication straight away, the drugs, are you saying that the drugs for PEP and PrEP are exactly the same or not?
They're exactly the same. There's no difference whatsoever. So they're interchangeable in that sense. They are different in the sense that from a PBS perspective, so PEP is not funded by PBS, whereas PrEP is. But I mean, that's only really an issue for people that have a one-off event that aren't an ongoing risk. So in the majority of circumstances, both the script that you would write and the drugs and everything is all the same. The critical difference is the urgency at which you need to put them on it.
Yeah, so the vast majority of cases like this would be the same medication, so Truvada or tenofovir and emtricitabine is what we're talking about. In some situations, people at very high risk then will add in another drug for PEP as well. Is that correct?
Yeah, that's true, and that's another reason why we're saying to call the number, because they will be able to advise you of whether that was required or not. So yeah, essentially, if you ascertain a risk, you ring up and then you find out how to get access and whether you do need that third drug or not. So your third drug is definitely, yes, it's different, and you wouldn't be able to get that through a PrEP script.
Yeah, and the people are on the end of the hotline having coffee with their friends, and they always seem to be very happy to take your calls and just sort of ask all about the sexual practices while they're having a burger and chatting away. So it's a good cafe discussion for them when they're on call. But so the other thing is, just to reiterate that if you are getting people to be on PrEP, then you've got a bit of time up your sleeve. You're wanting to do the HIV test and check their kidney function, and if that's all okay, then get them onto it. If it is PEP, then certainly call up the number and just ask where to go, because you might need the patient to go to the emergency department rather than their local pharmacy, because your local pharmacist might not have it available, and you're not wanting them to sort of delay getting it if they're needing it early, and waiting for 24 hours for the pharmacist to order it in. Yeah. So so here's a tricky question. So what if Jason's test comes back as HIV positive, Nathan?
Yeah, so that's actually on the flow chart, and it sort of provides a bit of information of what to do there. But essentially, obviously, if the person comes back with a HIV positive result, then they're not a PrEP candidate, and we need to manage them from a HIV perspective. So if you go on to the next slide, got a bit of information there about a great program that we have in New South Wales called the HIV Support Program. Actually, often when I talk about this, a lot of people say, why don't we have this for other issues like a cancer diagnosis and that sort of thing? But I don't know, you need to talk to New South Wales Health about that one. But essentially what happens is if you get a positive HIV result and you're not known to be a HIV specialist doctor, then the lab will ask you if you want to be contacted by New South Wales Health. If you say yes, then a de-identified notification comes through to your local coordinator. So for Hunter New England, it's me. Every area has their own coordinator that's a local doctor, and they'll sort of call you up at a time you nominate and help you work out where to go with that. The key thing about it, I guess, has got the 5 support services there, and I guess that's how we sort of conceptualize what the person needs. But really, it's an individual call between you and that specialist, and work out what you need. If you've diagnosed people with HIV before, or the person's really expecting it, it's going to be a totally different situation than if it's an unexpected diagnosis and it's the first one you've ever made. So sometimes it's, how do you give this unexpected result and immediate referral? Other times it's helping you do those early stages and getting it through to treatment sort of at an appropriate time. I think that's it for that one. Do you have anything else to add on that one, Brad?
Yeah, I just remember when I was diagnosing my first patient with HIV many years ago, and I was just like shaking when I got the paper through, and the lab calling me. So yeah, it's really great if you're nervous about it and don't know what to do, just to call the number. And people are used to dealing with it; they know what they're doing. So it's good to have a management plan before the patient walks through the door, so you're shaking less and looking less nervous when you're trying to give them that piece of news.
Yeah. And I guess one of the big reasons why we try and do that straight away is, that aspect of, delivery of the bad news and making that as appropriate as we can. But the other thing, of course, is if someone is HIV infected today, we want to get them on treatment as soon as we practically can. So you generally get offered a virtually immediate appointment at a specialist service. Yeah. So step 3 is to think about other testing. And so that's other testing beyond those basic baseline, mandatory tests. And so there's a few tests that are not necessarily mandatory, but they're pretty much routine. And so that's up on the slide there. So we want to test people for hepatitis C. So we've already tested them and vaccinated them if they need it for hepatitis B. But we also test for hepatitis C. And that's because although
there's just a question through as well from listeners saying, why do we need to test for hepatitis C although it's not known to be sexually transmitted?
Yeah, that was a great question, and I was just launching into that, so it's really good time.
Sorry, jumping in.
No, it's good. Yeah, so I thought that question would come up because it's a really good point. So yeah, basically hepatitis C is not really thought to be sexually transmitted. However, there are some studies showing that particularly very high risk for HIV gay men and gay men with HIV do have high rates of hepatitis C. So it probably is sometimes sexually transmitted. It does seem to be quite strongly associated with injecting drug use in particular, or other types of chemsex. So chemsex is where you're using stimulants and erectile dysfunction drugs during sex. So it does seem to be strongly associated with that, but because we've selected out a high risk group here for PrEP, it seems prudent to also test for hepatitis C. That's particularly important at the moment because, as I'm sure you all know, hepatitis C is easily treated with an 8 to 12 week course of treatment. So it's really important to identify that and treat it early. Does that answer the question, you think?
I think so, yeah.
All right. So yeah, so at baseline we test for Hep C. We also do STI testing. And so STI testing, it's chlamydia, gonorrhea, and syphilis. And remember that that's not just a urine. It depends on the site. So we'll also be doing anal and throat swabs for Jason. And if Jason, obviously Jason, well, I don't think we actually asked that, but I'm assuming Jason's not female. So if Jason was female, then we would definitely need to do a pregnancy test.
Yeah. And one of the other questions that's come through is if you do have the service at your clinic of doing like a finger prick test for HIV, when you're seeing somebody for that initial PrEP prescription, that PrEP consult, is a finger prick point of contact test appropriate, or do you need to send the blood off to the lab?
Another great question. We're getting really good questions tonight, aren't we? So we prefer a test from the lab. So the problem with a finger prick testing is it doesn't contain an antigen in it. Well, the one that does is the antigen doesn't perform very well. So it has a slightly reduced sensitivity for very early infection. So you have a longer window period. So we would recommend testing in the lab. You could do a point of care test as well if the patient wanted. But we would recommend to also do a lab-based test. However, that's not a sort of a hard exclusion, because we would recommend follow-up testing anyway. So if the patient was flat out refusing to do it, then I would prescribe PEP in that scenario. But I've started hundreds of people on PrEP, and I've never once had that problem yet.
Yeah. Okay. Oh, we'll go on to the next slide. So yeah, so we're just covering all of these points. So we covered these steps here. So we'll go on to reviewing what you'll need to discuss with the patient and when you're ready to give them a prescription, what's involved with follow-up, and then where do you go if you're needing further support or information. So Nathan, up for the next slide.
Okay, so you've already explained, Brad. So the name of the drug's on the screen. So it's tenofovir disoproxil fumarate with emtricitabine. They're all fixed dose single tablets, and they come with a number of different brand names. It's all done as 30 tablets with 2 repeats, and the streamline code, which hopefully will pop up in your software, but it's 7580. There are the different codes if it's for HIV treatment. So it's recommended that people take it daily. There is some data around intermittent and non-daily PrEP, only really in gay men. So if you're using it in another person, we would strongly recommend against intermittent PrEP or other non-daily regimens. In a gay man, if they really want to take it in another way, then I would suggest ringing for some advice, because this is a rapidly changing area, I guess, with the evidence around it. The reason why people other than gay men can't really take non-daily dosing is because the drug levels in the vagina are much, much lower than in rectal tissue, and so you really need to be taking it daily in that scenario. So that's basically what you need to know for a prescription. In terms of what you need to tell the patient, so if we move on to the next slide. So in terms of patient education, what the patient needs to know is that it's not going to work immediately that they fill the script. They have to take the tablets for a bit of time to build up their protective levels. So from their data, it looks like 7 days is protective for anal sex, 20 days for vaginal sex. But the recommendation from ASHM that releases the guidelines is that really everybody should wait 20 days if possible, but definitely for anal sex a minimum of 7 days. If they decide to stop PrEP, and people do because their situation changes, we've been amazed at how quickly people's situation can change. So you need to take for 28 days after your last potential exposure to consider you're protected. You need to warn the people about the potential side effects, and the main side effect people will notice is some nausea that really peaks at around 2 weeks and generally resolves by 4. Generally, people taking with food and experimenting with different times of day can avoid that. And the longer term risk is around kidney and bone disease. You need to discuss the importance of using condoms, because although PrEP is virtually 100% effective against HIV, not quite, but almost, it doesn't provide any protection whatsoever against other STIs. And so we really encourage people to think about continuing to use condoms, and talking to them about how they might make that decision. And the last thing is just a practical thing that, just to warn them that the pharmacy probably won't have it in stock, and probably will need to order it in. Generally, it's been coming in about 24, 48 hours in most pharmacies, so it's not a major panic. If someone mixes the pill, so it's similar to a lot of the medications, daily medications. So if you miss it by more than 12 hours, then you just skip that day. If you remember within 12 hours, you take it. It's pretty forgiving. We know from the data that 4 tablets a week is protective. So if they're missing the odd dose, that's not a big drama. Although I probably would use as an opportunity to get them to reflect on their adherence and just try and maintain it as high as they can.
Yeah, and that's if they're male and having anal sex. So if they're female, then it may not be as forgiving.
Yeah. Sorry, Brad. Yeah, really good point. So females definitely need to take it daily. And that's really one of the things that took a long time to work out why the female PrEP studies weren't performing as well. And that's when they worked out the vaginal tissue didn't have as much drug there, and it's really important to take it every day. Okay, so we're going to the next slide. So this is just a table. It's from the decision-making pathway that you've got, and it shows you the follow-up testing. So essentially, so you test the baseline, then we want to do a HIV test, and review of side effects and whatnot at 30 days. But then the main thing is every 90 days they come in and they have a HIV test, a clinical review for any side effects or new medical contraindications, full STI screen, and in females pregnancy testing, and then every sort of 6 to 12 months we're adding in the testing for kidney function, and repeat hepatitis C tests. Now, just to complicate a little bit, going on from what was asked before, not everybody does that Hep C test religiously every 12 months if someone doesn't seem to be at particularly high risk. But what's on the screen there is certainly what is in the national guidelines, that a PrEP user is by definition a high risk person, and doing a 12 monthly Hep C test is probably worthwhile.
Especially if their liver function's terrible.
Yeah, of course, yeah.
It's a good summary slide with that one. But yeah, we'll return to Jason. So Jason is coming back to you for a follow-up visit. So he's here for a repeat PrEP prescription. He's been taking PrEP every day and he's religious with it, so that's all good. Every day for 3 months. And he's had some episodes of condomless anal sex since the last visit. So we will go to a poll. So what tests would you offer Jason today? So A is no additional tests are required at this time. B is testing for HIV, chlamydia, gonorrhea, syphilis, and the estimated glomerular filtration rate. C is hepatitis A and B serology. And D is hepatitis C serology. So most of you are experts with this. So 92% of people are saying B for HIV, chlamydia, gonorrhea, syphilis, and estimated glomerular filtration rate. So yeah, so that's after the 3 months. And yeah, looking at the ASHM guidelines, it's pretty clear with the table that Nathan showed before. Yeah, what's the rationale for doing these tests, Nathan?
Yeah, so the rationale for doing the tests in terms of the STI screening is that people having unprotected anal sex that meet the PrEP criteria are going to be at increased risk of sexually transmitted infections. So it's really important that we are testing regularly. And I guess that's one of the reasons why we're pretty comfortable that although this is removing people's risk of HIV, and there's been some concern that that's going to lead to an explosion of unprotected sex and STIs, that hasn't eventuated, and we think that's partly because people are getting tested and treated regularly. So what we recommend is a full STI screen. So if we're looking at Jason, who's a gay man, so that involves testing for gonorrhea and chlamydia from urine, an anal swab, and a throat swab. along with a blood test for syphilis that you can add on, obviously, with the HIV because it's another serology. Hopefully, we followed guidelines and we made sure that Jason was immune to hepatitis A and B before we started. There is actually a hepatitis A outbreak at the moment in Sydney and Melbourne, so it's really important to make sure gay men have been vaccinated against hepatitis A. And hepatitis C is not, you don't need to do it at the 3-month mark. So we did it at baseline and we do it every 12 months. EGFR, as we said, it's every 6 months, but we do one at the first 3-monthly visit when they've had drug for the first time, just to make sure there wasn't an early impact. So we do that regularly. So someone on PrEP will be seeing us 4 times a year. And STI testing is recommended annually for all men with a male partner, but up to 4 times a year for all MSM, particularly any MSM that having unprotected anal sex, having more than 10 partners, having group sex, or using drugs during sex or chemsex, as we discussed before, or obviously HIV positive is not really relevant to PrEP, but if you did have a HIV positive person, we do recommend regular testing. So I think the next slide shows us just some get into sort of tips of how to get that done. Particularly bearing in mind the first poll where the lack of time is obviously a real barrier in this regard in general practice. So most of this can be done as self-collected swabs. So self-collected anal swabs and self-collected vaginal and throat swabs have all been validated and all perform as well as clinician collected. This little thing of how to do it, you can laminate it and have it in your drawer or on your toilet wall. Really quite clearly explains, even without having to necessarily even be able to read it, how to do it. Alternatively, of course, you can give them a form and send them to a pathology collection service. So it really should be doable within the context to get these tests done. I think.
And decreases the embarrassment if patients are doing it themselves as well. So yeah, good to have the signs up on the wall so they know exactly what to do. So so this is just a website for a reminder. So sti.guidelines.org.au. If you haven't gone to that website, please go to it and have a look. It's pretty easy to look at what the different STIs are and look at the latest management strategies in New South Wales. It's always up to date. So that's one of the good sites to go to. We're also recommending, if you're wanting to in the future, the next webinar that we're doing around PrEP is also managing positive results with HIV. So we'll be doing that a little bit further, and we'll be also focusing on contact tracing and partner notification as well. So we'll go on to the next slide at the moment. And this is what, Nathan, you were talking about this before, about the rates of STIs around New South Wales?
Yeah, so this is data from the EPIC study, which ran for about 2 years before the PBS listing of PrEP. And we got really good data around what's happening with STIs. So although there was quite high rates of STIs, as you would expect in a high-risk group, and possibly some slight increase in chlamydia, it's strikingly how stable these rates are. So over that couple of year period, we didn't really see any increase in STIs. But again, the rates are high. It's really a group that should be getting tested every 3 months.
Yeah. So, and lots of patients are just sort of going, oh my God, I've never been tested so many times in my life. This is amazing. I'm best friends with my GP. So that's always helpful. So if you've got a patient who's taking PrEP, but they're still at risk for STIs, what is your process, Nathan?
Yeah, look, I mean, that's really important because we do recommend people continue to use condoms. We're not sort of trying to send the message here that PrEP's the answer to everything. And so we do ask patients about their condom use every time they come in. We do talk to them about how they make those decisions. And I think this sort of brief intervention framework is a great way to go about it. So there's a tool on the Ending HIV site. It's got the link there, steps you through it. But essentially, it's the same brief intervention that you'll be using for smoking and other things. So really, helping the patient identify if they feel they're at risk and if there's anything they want to change. For me, that often comes up when the patient comes in with repeated STIs and said, oh, look, I'm a bit sick of this. Get into to identify, well, what are the barriers to you using a condom, for instance, and then helping them come up with some strategies for change. And it has to be quite practical. There's no sense just lecturing someone and saying, you're stupid, you should be using a condom. It's really about helping them work out, well, when do I, when don't I? how might I do it? So a lot of a common thing people might do is to really use condoms with the sort of random partners they don't know well, but they might have a couple of people they know well and they know are getting tested for STIs regularly. Maybe they won't use condoms with those people. So it's about them making a risk assessment and deciding what they want to do.
An additional advice.
So there's a few other things that you need to think about. So we've really gone through, by far and away the most common scenarios, but there's a list of things up there where you probably want to get some advice. So most of them aren't absolute contraindications, but there's situations in where you might want to have some different monitoring, or particularly if they're under 18, you might have issues with the PBS criteria. So that's where you might want to get some information. So you can call up the Sexual Health Info link, or any of your local sexual health services will be happy to either provide advice or potentially take over care if it's required.
Yeah.
One group really important to think about is Medicare ineligibles. So people who don't have a Medicare card but are at high risk of HIV. We don't want these people to miss out. So that's a really good group to think about discussing with your local clinic about how to get access, because there are means of getting access through personal importation schemes.
Yeah. And here's just a reminder, we're going to finish up in a couple of minutes, but this is just a reminder of the clinical resources that are available to provide support for everybody, a one-stop shop for PrEP resources with the website there, Ending HIV. Some of if you're in different areas around New South Wales, some of your local health districts will have different websites, and they should be all up to date with resources for your particular area as well. So please check out those websites. And this is just sort of going through what we've talked about. So just summarizing that you guys are who we're all relying on. So we're really pleased that you're here with us tonight and that you're learning about PrEP, because you will have patients coming in and we don't want any awkward conversations. So we want you to know what you're doing and know that you're giving PrEP to the right people. PrEP requires, or it's great to provide this with an opportunity to check for other sexually transmitted infections as well and make sure that we're treating everybody appropriately. Taking a sexual health history, we've gone through all of that, so hopefully you're all fully capable now. The clinical tools and resources, and we'll be sending some of that information to you as well after the webinar. And just really important to discuss a patient's risk of other STIs. We don't want to be forgetting about chlamydia or gonorrhea and syphilis if we're just focusing on HIV. So really, really important to check for all of those too. And I think we've covered most of the learning outcomes. I think that I hope that we've covered everything here. So so that's just a refresher with everything. And I really thank everybody for tuning in tonight and for learning how to prescribe PrEP appropriately. And a big thanks to Nathan as well for his expertise in this area too.
That's great. Thanks, Brad. And
thanks,
Nathan as well. And thanks everybody online for joining. And we hope you all enjoy the rest of your night.